All right. Hi, everyone. Again, my name is David Rubin. This is Stephen Goldberg, and we'll be going through a problem-based learning discussion on the paravertebral block, which in my opinion is the plan A block for most of your truncal surgeries. So we have no disclosures or conflicts of interest. And the objectives for today, so we'll go through a case scenario for an awake breast surgery, describe the regional nerve block options for breast surgery. There are a plethora of nerve blocks that you can perform for it. Depends on the type of operation being performed, whether or not you have to do it awake, if you can go to sleep. Also, the patient's buy-in is a large part of it. If you're doing an awake breast surgery, not only do you have to perform very good analgesic techniques, but you also have to have a degree of patient buy-in so that they know what to expect. We'll go through the role of the paravertebral block in breast surgery, go through the anatomy of the back and how that translates to sono anatomy, and then we will do a live demonstration on the ultrasound here. All right, so case scenario, this was a patient that we had at the start of 2025. It was a 78-year-old female. Past medical history of COPD, not on home oxygen, GOLD 1B criteria, active tobacco use, significant smoking history, and then she had a segmentectomy a year prior. She was presenting for a right-sided mastectomy for invasive mammary carcinoma. So she's probably not the worst patient that you'll just see on paper from a pulmonary standpoint. However, notable for her, following her segmentectomy, she was not able to be extubated. It took her 5 days in the ICU to be weaned from the ventilator. So not only does she have a recent history of being unable to be weaned from the vent, but she was very motivated herself to avoid that. So she was very much bought into the idea of doing this awake or with light sedation. So COPD history, she had an exacerbation 3 months prior. She saw pulmonology, who said she was optimized to the best that they were able to. Very poor functional status. She is very dyspneic walking a city block or going up one flight of stairs. And even just getting into the bed in the pre-op area, she was quite short of breath. So she was deemed a moderate risk patient for a moderate risk surgery. Her pre-op vitals were not particularly notable, 96% SpO2 on room air. Her weight was 37 kilos, which did limit the amount of local anesthetic that we could use. So she was very small. Fairly unremarkable echo. And then her PFTs, her biggest problem was her diffusion deficit. And she had mild obstructive diffusion. And then again, her functional status was the worst part of her pulmonary function, which is she just becomes very dyspneic with really any sort of activity. Let's see if I can. So real quickly from the audience, what are some options for analgesia that you would do for her, including regional anesthesia, but also any other multimodal techniques? And if not, I can just go through some. So you can do some, obviously regional anesthesia. So paravertebral is what I would consider the best option for her, but what other places are doing, you have really a whole smorgasbord of techniques. So you can do the superficial or the deep PEX, so formerly the PEX 1 and PEX 2 blocks, the PIF blocks. You can do a pectoserratus block, which is the deep pectoral block. So there's a whole bunch of regional techniques, but then you can also do lidocaine infusions, ketamine infusions, and then multimodal analgesia with Tylenol, ketorolac, if that's an option. So what we did for her, we did a preoperative multi-level paravertebral block, and we were limited to 22 cc's total of 0.5% ropivacaine, which for her was adequate. Again, she was very small, and we used dexamethasone as our additive to try to buy a little bit longer period of analgesia on the backside. That being said, we did perform levels, and in the middle level at the T4-5 level, we placed a catheter. We ended up hooking up to an infusion and had on for several days for continuous analgesic relief. So we had 3 injections, 7 and 7 cc's at T2, T3, T4, T5, and then T6, T7. For the sedation, so she actually was this is a decent amount of sedation, but she had high requirements. So even with a Precedex of 1, she was more of a, I'd say, moderate sedation level. So if you gave her a little tap, she was able to respond to you, in having the ketamine on board. And you can see here from her vitals, around the time she basically had no reaction. So around incision time, she was fully talking to us. The end of the room had some decent jokes, so she telling some jokes. And she had no reaction to any stimulus throughout the duration of the surgery, as you can see from the flow chart. So post-op, she did have some post-operative hypoxemia, thought from a little bit of atelectasis. She was put on 2 liters nasal cannula, wasn't able to be weaned off in the hospital, but a course of a month with pulmonary rehab, was able to get it off. Now, we were hoping to have no oxygen at all, but when you compare it to her prior surgery, being unable to be weaned from a ventilator, I think that 2 liters nasal cannula was victory from our standpoint. Okay, so as to what block you're going to perform depends on, number 1, the surgery being performed, and number 2, the incision that is going to be required from that surgery. You can have, there's a multitude of breast surgeries, of course. You can have a simple lumpectomy, which obviously can be anywhere on the breast. You can have a simple mastectomy, a skin-sparing mastectomy, a nipple-sparing mastectomy. You can have spacers or expanders placed, which not only gives you get dermatomal incisional pain from the actual, you can get some myofascial pain from the expander being present as well. And then the incision can vary. It can be S-shaped, it can be inframammary, it can be wherever the location of the lumpectomy. And then on top of that, as to what the surgery is depends on the patient's goals of care. So you really do have to talk to the surgeon preoperatively because, mastectomy can have a lot of different incisions. So it's not just you see mastectomy on the schedule, oh, this is what they're going to do. You really should talk to the surgeon. And then are they going to do a sentinel node biopsy because then it extends into the axilla, which is a little tougher to as well. So you can see here from this image, so paravertebral, and we'll go through the anatomy of why this is, but paravertebral is going to cover basically front to back around the entire chest. You have the nerve on the side gives off the lateral cutaneous branch, which cover the side of your body. And then the intercostal nerve comes around and gives off the anterior cutaneous branch, which this on the front of your chest. If you break it down on the other side of this figure here, you see the pectoserratus block and the serratus anterior. They cover the side because they only get the lateral cutaneous branch of the intercostal nerve, and then the PIF block, the parasternal intercostal fascial plane block, only gets the anterior cutaneous branch. So you're only going to get midline coverage. And then on top, if the incision does go closer to the clavicle, you have the skin coverage from the supraclavicular nerves, which is nerves that come down from the cervical plexus. So if you were to cover that, you would have to do a superficial cervical plexus block. All right. So benefits of paravertebral blocks in breast surgery. It's very similar to the benefits of regional anesthesia in general. And very well established what the benefits are in many papers. Just to name a few, decreased chronic surgical pain. So there is a incidence of chronic pain following breast surgery, and this helps to reduce that. Obviously, this is going to reduce your acute post-op pain as well, especially if you end up leaving a catheter behind. Paravertebral block, compared to the chest wall block, it does have a lot higher reliability. So if you absolutely need to stay awake, there's no question that paravertebral is going to give you the most consistent, reliable coverage to keep them awake and to prevent having to convert to general anesthesia. And numerous quality of recovery benefits. So this is a short list of them, but reduced pain scores, reduced opioid consumption, shorter PACU stay, decreased PONV. So all things that were, and moving on. So what are the complications of a paravertebral block? The complications are fairly low, especially in the hands of someone who is proficient in ultrasound use. Pneumothorax, through how it works, but you're placing local anesthetic right next to the lungs. Surprisingly, the incidence of pneumothorax is extremely low, so about 2 to 3 in 1,000 blocks. And it's a very small needle that you use, so even if you do accidentally go into the pleura, typically they're not going to develop a significant pneumothorax, at least one that's not clinically relevant. Sympathectomy, so if you're doing it in the thoracic region, you will likely get spread to the stellate ganglion, so you'll see some syndrome, and that tells you that your block is working, so that's actually a good thing, and go away as the block wears off. You are near the cardiac accelerator fiber, so you are going to get maybe some bradycardia, but certainly some hypotension. But if you're comparing it to an epidural, the hypotension is a lot slower, so you have a lot more time to treat it. And degree of hypotension tends to be much less than a thoracic epidural. And inadvertent intrathecal injection. This would certainly be the worst of the complications. You would have to have some pretty unlucky anatomy. The dural sleeve would have to extend out of the intervertebral foramen. And on top of that, you would have to go into it. So it's a possibility. I saw one case report on it, and most of it is a theoretical concern, but it is a theoretical concern. All right, so the anatomy of the paravertebral block. Let's see if I can zoom in. So I'll do it over here. So the anatomy, so this is the nerve here. And as soon as the spinal nerve leaves the intervertebral foramen, it splits into two parts. It splits into the ventral ramus, and at the level of your ribs, the ventral ramus is the intercostal nerve, and the dorsal ramus, which goes through ESP muscles and innervates the skin over top of your back. And also important is the ganglion here. The pain fibers go through the sympathetic ganglia and then synapse through the cord, going through these rami communicantes. So as the intercostal nerve makes its way around the body, it gives off two sensory branches. So this is the intercostal nerve. On the lateral side of your body, it gives off a sensory cutaneous branch, which is going to innervate your skin around the side of your body here. And then the intercostal nerve makes its way anteriorly and will give off the anterior cutaneous branch, which is going to innervate the skin on the, of your. So the anatomy of the paravertebral space has been better defined over the years. On the left here is the older model, which showed the SCTL, that's the superior costotransverse ligament, which is one of our main anatomy landmarks on this block. So you have your superior costotransverse ligament, which connects the TP superior vertebrae to the rib on the inferior vertebrae or rib. And needle has to go anterior to that. So you're going to bring your needle posterior to anterior, and you're going to go past the TP through this SCTL, and you're going to leave the local anesthetic in this paravertebral space. That paravertebral space is bound, it's a triangular space. The anterior lateral part is bound by the lung. Medially is the body, and then the posterior boundary of that is the SCTL. Now, it used to be thought that you had to get anterior to it for any local anesthetic to get to the intercostal nerve, which is really your target. That's really what you're trying to anesthetize, because if you anesthetize the intercostal nerve, you're going to be getting the lateral cutaneous branch and the anterior cutaneous branch all at once. But the paper showed with micro CT scans and MRI scans that there are a bunch of slits that basically makes it a continuous space between the paravertebral space and the retro paravertebral in green here. So the goal is to bring the anterior to the superior costotransverse ligament. If you don't because of poor scanning or whatever the issue is, then you still should get some communication, although it's going to be sometimes less reliable. All right, and let's see if this, oh, it does. All right, so this is using the app Complete Anatomy, and I'm trying to scan in. So that right there where my mouse is, that's the superior costotransverse ligament. You can see here the ramus is coming out and going through these P muscles to the back. This here is the intercostal nerve, which lies anterior to this SCTL. So you're going to bring your needle from posterior to anterior and deposit your local anesthetic right here, anterior to that superior transverse ligament, which again is then going to anesthetize the entire intercostal nerve and get really dense analgesia all around. All right, so sonoanatomy. So there's several to this block. The two main ones are going to be paramedian sagittal oblique approach, which is what we typically use at Jefferson, and then also the transverse intercostal approach. So starting with paramedian sagittal oblique. So this is with the probe angled straight up and down up the body, with the left being cephalad, the right being caudad. You can see here the processes, this transverse process here. Here, if it was a live demonstration, would be the shimmering pleura. And then this hyperechoic white line is the superior costotransverse ligament. So you're going to bring your needle straight down out of plane. So you can do little puffs of saline to help you hydrolocate where the tip of your needle is. And you're going to go straight past this SCTL. You'll feel typically a pretty good pop because it's a thick ligament. And then you'll leave your local anesthetic right here. And you'll see a depression of the pleural line. And that depression will tell you that you're leaving your local anesthetic in the right spot. So again, that space is that paravertebral space. Next, the transverse intercostal approach. So this is with the probe in the transverse orientation. And this approach, you use an in-plane approach with your needle. So you're seeing your needle the entire way. What we have here on the screen, well, I'll just go to the next slide, actually. So all in one image on the very top left of the screen, you have the spinous process, and then it dives down. This is the lamina of the vertebral. This is the transverse process going up, and then it dives down, and you would see the pleural line here, the internal intercostal membrane here, which is one of the boundaries of the space, and you bring your needle from lateral to medial and go through that intercostal membrane and deposit your local anesthetic right there. This is a great option. The concern for this approach is if you don't have good visualization of your needle, you are driving it towards the neuraxis. So you don't want to go too deep, obviously. So as long as you have a good in-plane view of your needle, this can be a very effective approach for the paravertebral block. How many injections should you do? So if you're only doing this for analgesia and you do not need this as your primary anesthetic, this paper showed that doing a single block of 25 cc's was basically equivalent to doing 5 separate levels, 5 separate injections. So in the blue, the bars was a cohort of patients that received a one-time 25 cc block. And the bars are a cohort of patients who received 5 separate 5 cc blocks. And what this shows on the bottom, the x-axis is the level of loss, so T1, 2, 3, 4, 5, 6, 7, 8, and percentage of patients on the y-axis who had sensory loss at that dermatomal level. And you can see they basically look the same. So if you're just doing it for analgesia only, not for relying for your primary anesthetic, then doing one single injection is absolutely sufficient. If you are using it for your primary anesthetic and you have to depend on it, I do think that you get some level of redundancy and by performing it at multiple levels. In the event that your one injection doesn't spread particularly well, it doesn't get anterior to that ligament that you're trying to get through the SCTL, then you have some backup through the other injections that you made. But you're only doing it for analgesic purposes, then one is enough. These are my references, and that's it. And now we're going to do some live scanning on a standardized patient. So we'll go through both of those approaches. First, we'll start with the parasagittal scan, parasagittal oblique, with the probe oriented vertically.
It's good practice to always start by identifying exactly what rib you're at or what level of block you're going to be doing. So I always go up and identify the first rib. And that's easily accomplished by finding the ribs and then seeing where there aren't any. That way, then looking at is the first rib. So I start out pretty laterally. Just the ribs are more superficial and easier to find. And then I'll just count down so you have basically the first rib here, second, and I'll just continue to scan down until I get to the level that I want. So this here will be about the fourth rib. And then I will scan in to find the transverse process. So the ribs, as I mentioned, are more superficial. So what you're going to see as you come immediately is they typically will become a little deeper, and then they'll transition over to the transverse process. It's going to come deeper, and then it'll transition over. Transverse process there. You can see how the transverse process is a much more square appearance compared to the rib, which is right here. You'll also be able to see the flora right down here, which is going to be shimmering and moving around. And then the SCTL should be right up here on this line. So your block is going to be coming essentially right down through here. So pop through there if you're coming out of plane, and then you'll see depression of the lung below it. Something that's important to remember here if you're having difficulty at visualizing the flora is that this is right in the area where the lung starts to curve around and move anteriorly. The best way to visualize anything is to have it be perpendicular to the beam of the ultrasound. So if you're holding your perfectly straight back, your probe perfectly straight back, you may not see the flora moving. And what is helpful to do at that point is to just start to tilt the probe to angle it laterally and band laterally, and that way you'll catch the lung at a more perpendicular angle. So the other view that is the transverse. So you start there with identifying the spinous process, which is right in here, that black shadow, and you can from there move out. This is going to be your transverse process right here, and then you'll get a nice view of the over here, and you can see that moving, sliding as you'd expect. And then right in that triangle where the flora comes in to meet the transverse process, right in here, that's going to be your target for your block. And you can either do this in plane or out of plane, depending on your level of comfort. But I think that getting familiar with both views is probably a good idea, because there's some people where the parasagittal view image is better, and some people where the transverse view is a more favorable image.
Now, so individualized block for breast surgery is also the ESP block, which is great for analgesia, but certainly I wouldn't use it as my primary anesthetic. The reason being, as far as anatomy goes, reliability for the ESP can be an issue sometimes, and there's a multitude of reasons why that might be the case. One of the big ones is as you come in with your needle towards the EP, your end goal. So in ESP, your end goal is to put your needle right here anterior to the SCTL. ESP blocks, your goal is to hit this TP, deposit a whole bunch of local anesthetic right here, and then hope that that anesthetic tracks anteriorly through these medial and lateral slits and to the intercostal nerve. Issues up. Sometimes it doesn't always do that as you hope. The thoracolumbar fascia envelops this P muscle, which is right here, and you don't always get through that thick thoracolumbar fascial plane. So a lot of the times when you give that local anesthetic, it stays within the ESP muscle group and get to the intercostal nerve. So good block if the goal is just analgesia, but if you absolutely need it for your primary anesthetic, ESP would not be a great option. And can we show ESP and where our target would be for that?
So it's kind of the same idea. You're going to start with the ribs immediately, do the transition over right there. Nice squared off appearance. And you're basically going to be coming in and contacting the TP directly. This is all erector spinae muscle here. There's a plane right here where you're going to put your local, and you should see the erector spinae muscles lift up. And it's pretty normal to see the muscle lift up and then come back down as the local anesthetic diffuses throughout that tissue plane. So there's your view. You can see you're sliding here, so this is where you're going to contact. And as earlier, with now that we have those micro CT studies showing the slits between the SCTL, you don't have good visualization of the pleura. You can just put your local anesthetic. It's called an MTP block. It's the midpoint of the transverse process. So anesthetic should get down into the paravertebral space without too close to the pleura. And if your goal for your block is primarily just to achieve analgesia, you should be able to do that. Although I'm not sure that I would necessarily trust that if that was going to be your anesthetic. So you basically come about halfway down the transverse process and you can deposit your local there.
Yes. Benefit of an MTP over your ESP is, in my view, is that you basically know you're getting through the thoracolumbar fascia and you're definitely depositing the local anesthetic just behind this SCTL. So there's more reliability in terms of getting anteriorly to this intercostal nerve. Yeah, reason to choose an ESP or an ITP, mid-transverse or intertransverse process block over the paravertebral block is we treat the paravertebral block as a deep neuraxial block. So you do want to follow ASRA guidelines so you do always want to check that before you do a vertebral block. Less important for ESPs, and mid-transverse point is kind of a gray zone between those two, but I would certainly feel better doing that over a paravertebral. And that's it. So the talk is all finished. Anybody is welcome to come in and try to scan if they would like. But if not, we can take some questions and that'll be it. Yes. If it was bilateral, I would be much more likely to do an epidural. If they have any hemodynamic concerns, and high on your differential of, could go wrong during the surgery, then I would lean towards bilateral paravertebral. But, patient, the amount of volume that we could use, even on one side, was so limited that we basically wanted to use that also. For this patient, we wouldn't have had the volume to do bilateral paravertebrals. And for that reason, you probably should try to do an epidural. But a lot of these patients are sicker, are anticoagulation, so that always has to be before you perform your block. Yeah.
Still in a block like this, essentially getting high thoracic.
Yeah. So you have an impact on your respiratory status. So the big concern would be if it gets your phrenic nerve, which we're certainly far from being C through 5. But on top of that, you also hitting the intercostal nerve. So you are going to take out some of your muscles, accessory muscles for respiration. So you get a little bit of a decrease in respiratory function, but when the alternative is putting them on a ventilator, I think that you're choosing the lesser of two evils. Just the accessory muscles alone usually doesn't cause a significant change in respiratory status. And we're not getting too north of a spread where you're going to hit the phrenic nerve. If you're up in the If it gets up in the cervical vertebrae, then you've performed a phenomenal block because your spread has been terrific. But yeah, you really see that. Again, one block, if you put 25 cc's at one level, you'd expect to see about 2 levels up and down for a large volume block. Okay, thank you guys. Oh yeah. Yes, that's gonna depend on the patient's body habitus. Honestly, the higher frequency probe that you can get away with, the better. So if you're imaging is 2 to 3 centimeters, then I would certainly use a linear if you're able to get away with that. Once you start going into the 4 or 5 centimeter range, that's really when you want to change to a curvilinear probe. But the answer is that if you can get away with a linear probe, I think that's better because you'll get a sharper, crisper image of that SCTL, which can be a little tougher to see on a curvilinear probe sometimes. But really, it's whatever you can get away with. Yeah. So it would be depending on the location of the incision. So the serratus anterior block or the pectoserratus block is going to get your lateral cutaneous branches, which is going to anesthetize the skin all the way up until about basically your sternum. And then the PEX 1 block, or now it's called the interpectoral or superficial, they're changing names all the time, is going to get the lateral and medial pectoral nerves, which is, it's not a sensory, that has no cutaneous coverage. It only has motor innervation to your pectoral nerves. But when you put a spacer or any sort of reconstruction into that space, you're going to get this myofascial dull, achy pain postoperatively. So if all of the incision is outside of the coverage of the anterior cutaneous branch in the middle, then you can get away with that, yeah. But if the incision is going to extend more medially, then it would not be sufficient. Thank you, guys.